Professor Le Roux comes originally from South Africa, but currently holds the chair of pathology at University of Dublin. Carl has published widely in the mechanistics of appetite control, how the gut speaks to the brain, but today he's going to tell us about the modern metabolic clinic.
Well, thank you very much for this opportunity. And I actually remember in 2004, I was en route to an Australian wedding and found myself in Melbourne on Christmas Eve. And I rang John Dixon up and I said, I met him at a conference earlier in the year, and I was sort of just starting to set up our own metabolic clinic in Imperial College. And I said, John, can I come and see what you guys do? And he says, no, come around. And I met him. I sat him in with his while he was seeing some patients. I also met Wendy Brown in the same clinic. And what I always remember is Wendy had a stethoscope. And I said to her, you're a surgeon, what are you doing with a stethoscope? But not only did she actually have a stethoscope, she actually diagnosed a mitral stenosis in clinic while I was there. And then that actually helped me form my ideas about how a metabolic clinic or a modern metabolic clinic should be functioning. And we used a lot of what we learned and traveled the world, and because we really had no clue how to do this. So by actually seeing how other people are doing it in different health settings, that helped us develop what was now called the first tier 3 services in the UK, where we had psychologists, psychiatrists, dietitians, physicians, surgeons working together. But at the middle of this team, as many people always say, is this patient that comes to our clinic, and you know her very well because she comes to your clinic and she tells you that losing weight is really easy. Every time she goes on a diet, she loses weight. But this little devil is coming around, and every time she goes on a diet, she becomes hungry. And she'll tell you that she's never been as hungry as when she's on a diet. And you can ask anybody that's ever been on a diet, and they will tell you that hunger is a natural consequence of dieting. And of course, if they don't have that, they don't have normal physiology, and that's the really interesting patients to study. But as our sort of clinic evolved, and as we actually tried to work out how to operate in this multidisciplinary or interdisciplinary fashion, we also got stuck in our own little ways of what we wanted to do. And I worked in one of the best appetite labs in the world, in Steve Bloom's lab. And it struck me that although we were seeing patients, many of the people doing PhDs in the lab didn't see patients. And when we were sitting around in the coffee table, so many of them would say, why are you bothering with this? Because all people, what they should do is just eat a little bit less and do a bit more exercise. And so now what we've actually changed the way we work, so when we actually have new people who come in to our clinic, we actually ask them the question, is obesity a disease? And of course, it's like Sunday school, the answer is always Jesus. So, yes, obesity is a disease. And then we say, so if it is a disease, does it adhere to any of these criteria? So this is typical criteria, so it's a disease is any deviation from an interruption of a normal structure or function. So we say to them, so which structure, I'm not talking about the complications of obesity, but which structure is abnormal, and what function is indeed abnormal of a body part. But then what really starts, sort of making it really difficult for them, and when they start sweating, is when we actually say to them, so tell me what are the symptoms of obesity, not the symptoms of the complications of obesity. Don't tell me about diabetes or osteoarthritis or sleep apnea. What is the symptoms of the disease of obesity? So what we have sort of decided amongst ourselves, through consultation between ourselves mostly, is like the primary symptom of obesity is either excess hunger or reduction in fullness when people eat. Those are the symptoms that we are trying to treat in our modern clinics. And once we actually have decided, that, we as so-called specialists don't really understand the etiology of obesity, we don't really understand the pathology, and we don't even really understand the prognosis of most patients that walk through. But at least if we can start in our multidisciplinary clinics to actually address the symptoms of patients, i.e., can we make them feel less hungry, or can we actually make them feel more satisfied once they have a meal? Now suddenly actually working in a clinic becomes far more enjoyable, because what we're not doing is just chasing kilograms. Because by chasing kilograms, I don't think we've done many of our patients a service. So we would suggest to you, and this is controversial, but 80% of gene-wide association studies would point that most of the genes associated with obesity is in the central nervous system. And now we actually are becoming much better at understanding not only the hypothalamic, but also the nucleus tractus solitarius, really the subcortical areas of the brain. So maybe, and we would suggest, that obesity is a subcortical brain disease. And you can ask any endocrinologist, when we actually treat other hypothalamic diseases or subcortical brain diseases, we find it pretty challenging. And certainly just using supratentorial, brain functions by talking to people and, trying to change their behaviors with talking therapies can go some way. But you can go and do this experiment this afternoon or this evening when you go home and just before dinner, when you sit down in front of your dinner plate, and you have worked up a good appetite during this meeting, sit down and then for the next 5 minutes, just convince yourself that you're not hungry. Okay? Most of us will be good enough to convince ourselves not to eat, or you can force yourself not to eat, but most of us cannot really convince yourself to feel less hungry than you are. And that's really what we're very often asking our patients to do. So what we've decided to do is to actually use a sort of a very biological model and to actually see the natural ways of how the body actually makes you feel less hungry or makes you feel more satisfied. And we know that that's neural components as well as hormonal components, and now we understand the metabolome and how those signals are happening. And it turns out that the gut plays a very important role in actually making us feel less hungry or more satisfied. But it's really only when we started working with patients who've had bariatric surgery, either gastric banding or gastric bypass in our experience in the early parts of the 2000s, that we really understood that the patients who came back to us as internal medicine doctors, they came back to me and said, doctor, where did the surgeon operate? Did he operate in my tummy or did he operate in my head? Because all the effects after the operation is now in my head. So for the first time in my life, I wake up in the morning and I'm not obsessed with food anymore. I don't think about food anymore. Or now I eat food and I actually feel satisfied after a small portion. And that's really what drove us to understand that it's biologically possible to make people feel less hungry. And that's what we see in our hands, predominantly with gastric banding, where patients maybe only eat once or twice a day and actually feel not hungry, not driven to have food. Or the gastric bypass sleeve gastrectomies, where people actually eat more frequently, but when they do eat, they eat smaller portions. We think that drives most satiety. So these operations work completely differently, probably through completely different brain mechanisms, but actually both have an effect on long-term outcomes. Using functional MRI, we have shown that we can actually show after this operation how blood flow changes within the brain, and specifically to the areas that has to do with reward of food, consistent with the symptoms that we are hearing of patients after these operations, saying that for the first time, I'm not bothered with food anymore. And actually, when we see the changes in the reward centers are consistent with that. So our working hypothesis is that if people eat food, the more food they eat, the more satiety they will have. But what we see with obese people, this is shifted to the right, and therefore they have to eat more food to actually have satiety. And actually understanding that in a metabolic clinic, that our patients don't have a lack of moral fiber, and that's why they developed obesity, but they actually have a biological disease that changes how they interact with food, allows us not only to be more compassionate when we treat them, but also allows us to actually focus on treatments that can actually do this. Because if we can shift the curve to the left by actually making them feel more satisfied after they've had food, such as we can achieve with specific diets, with high protein, low glycemic index diets, we can achieve this with pharmacotherapy, we can achieve this with bariatric surgery. Now suddenly it becomes much more pleasurable to actually treat people, because when a patient fails to lose weight, it's not my sort of failure because I don't have any magic on that day, or the patient that's not listening or not compliant. It's merely just the biology that we're trying to address. So I will conclude that in our opinion, obesity is a complex and chronic subcortical brain disease, And by being able to measure brain signaling, we were able to help define obesity as a disease in our own service, and that helps us focus our attention. And the disease obesity are now being considered for personalized medical approaches. And what we really want to understand is how can we get the best treatment or the right treatment to the right patient at the right time. And certainly we're learning a lot from cancer and how we've addressed this in the past. So please just allow me to thank the team that's actually doing all the hard work back at home, as well as our international collaborators. Thank you very much.
Thank you.